A very warm welcome to all our PHYSIO viewers. As we move towards yet another interesting talk on our PHYSIO, let me first introduce to a very exciting upcoming workshop that we are going to have at Sancheti Institute, College of Physiotherapy, Pune. We at Sancheti have always been collaborating with faculties, national as well as international, to bring you all the best courses and workshops that can help you all educate and grow in your professional field. With the same intention, we kind of bring one of its kind, a lower limb dysfunction workshop, assessment to management. So it's basically going to be the advances in lower limb dysfunction assessment to management workshop, which is going to be coming up in Feb 16th to 19th of 2023. We have managed to kind of rope in some of the best in the field with 4 international faculty and 3 national faculty to bring you all the entire lower limb universe of assessment to management of conditions. This workshop is unique because we are going to have our course director, none other than Dr. Anil Bhave sir, who is the chief physiotherapist, she's clinical director at the Sinai Rehabilitation Center at Rubens Institute of Advanced Orthopaedics, Sinai Hospital, Baltimore, Maryland. Sir is also the director of the Weisserman Gate Laboratory and has close to 80 publications in peer-reviewed journals, along with patents to many of the devices that are used for betterment of the patients. He has also been one of the co-founders of the Multiplier app, which is used for deformity correction by orthopedic and pediatric orthopedic surgeons all over the globe. Sir has been a known name in musculoskeletal rehab, and he has collaborated with Sancheti in many of the workshops in the past. We had conducted this lower limb workshop about 2 years ago, and then unfortunately we had the lockdown, which was the pandemic which came about, which kind of delayed our courses, which we were supposed, this workshop was supposed to be a recurring feature for all the years, but we had to kind of take a break. But very fortunately, after the pandemic is behind us, we have been able to bring up this course again. And this time around, it's bigger and better. So this time we are going to have a complete hands-on 4-day workshop, intensive workshop, which is going to deal with assessment to management of all the lower limb dysfunctions that we encounter as a physiotherapist from the musculoskeletal part of you. This workshop is going to have, as I just mentioned, Dr. Anil Bhave as our course director. And along with him, he is going to get his colleague, Dr. Annie Neuror, who's a sports physiotherapist and a motion specialist. We also have Dr. Brendan Gladkin, and we have Dr. Joseph Zeni, whom I'm going to introduce shortly. From the national faculty, we have the star of physiotherapy from India, or our whole national physiotherapy community, Dr. Deepak Kumar from the Capri Institute. And of course, it's going to be Dr. Apurva Shimpi, who's a very well-known figure now in physiotherapy profession. He's also the associated with the research wing of the Western Zone of IAP, that's Indian Association of Physiotherapists. It will also have me as a faculty. And as we move on, I'll be giving you certain highlights of the workshop that is going to happen. So the unique thing is this workshop is going to be certified by the Capri Institute, New Delhi, by Sancheti Institute, Pune, as well as from the Sinai Rehab Center of Baltimore, Maryland. So we are going to have certification. So it's going to be a certified course, which is going to be credited by 3 institutes, top institutes, 1 international and 2 national. Apart from that, we are going to have a lot more because it's going to be a complete hands-on. So we are going to have a transcript, which is going to describe your hours in terms of soft tissue mobilization, joint mobilization. You're going to have the first time in India of complete hands-on training on blood flow restriction therapy with the latest apparatus, which is used globally. We are also going to be having taping, dry needling, and all the therapeutic maneuvers that we are going to be using. There's going to be biomechanical markers as well as training for how we can change the biomechanical markers in osteoarthritis and make patients better by knowing how the patients are going to advance in their disease. We are going to cover the gamut of entire surgical as well as non-surgical cases. We are going to know about athlete assessment, rehabilitation of various sports injuries. We are going to know about arthroplasties, whether it's the knee or the hip. We are going to know about all kinds of fractures in the lower limb and how to go about with its management. There are going to be real life case discussions and exchange of ideas. And we are going to have a complete revision and summarization of the course at the end of it. There are going to be working lunches also, in which you are going to kind of know about how to correct deformities of the lower limb and how to kind of formulate or kind of fabricate a brace, an easy brace, making use of local materials to treat contractures of the lower limb. It can be a knee flexion extension contracture, or it could be an ankle plantar flexion or dorsiflexion contracture. So we are going to learn a lot. We are going to kind of have the masters with us. We are going to have all these people, and we are going to work in modules. So we are going to have, it's going to be literally like a personal training with the masters of physiotherapy. So we are looking forward to registrations from everyone. And I'm sure the ones who are going to register are going to know that it's a once in a lifetime kind of opportunity that you're going to get in getting to know everyone who's associated with this field. So now as we move on, today we have one of our faculties who's going to be associated with the lower limb dysfunction workshop, Dr. Joseph Zeni. Dr. Joseph Zeni Jr. has received his bachelor's and master's in physical therapy from the Quinnipiac University. And after working at the Rubens Institute of Advanced Orthopaedics in Baltimore, Maryland, he attended the University at Delaware, from where he received his PhD in Biomechanics and Movement Sciences in 2008. Currently, Dr. Zeni is an associate professor in the physical therapy program at the Rutgers University School of Health Professionals in New Jersey. He teaches anatomy, medical imaging, and evidence-based PT management courses. For the past 15 years, Dr. Zeni has maintained an active research agenda that has focused on measuring and improving biomechanical and functional outcomes for patients with hip and knee OA. He has particular interest in assisting patients to return to high-level vocational and recreational activities after joint arthroplasty. Dr. Zeni is also currently a co-investigator on a clinical trial that incorporates biofeedback for patients undergoing total knee arthroplasty in order to improve biomechanical outcomes and preserve the long-term integrity of the non-operated knee. I now pass over the session to Dr. Zeni.
All right, welcome everybody. I am happy to be talking to you today. Today I'm going to give you a little bit of a preview about what I'm going to be talking about come our February course in India. And the topic I'm going to cover today is really related to biomechanics and knee osteoarthritis. My name is Joseph Zeni. I am a physical therapist as well as a PhD. I have my PhD in biomechanics and movement science. Currently, I am an associate professor at Rutgers University in the School of Health Professions. That is in Newark, New Jersey in the United States. And if you do have any questions about this talk or about biomechanics and knee arthritis in general, feel free to email me. My email is right here. So a couple quick disclosures. I have received funding from the NIH, which is the National Institutes of Health, for projects relating to physical therapy and patients with OA. And I've also previously served as a consultant for Amovi, which is a company whose products are discussed briefly in this talk, but they have no bearing on the content that I'm going to be delivering today. So if we're going to be talking about knee osteoarthritis, it's critical that we first talk about what actually defines knee OA. And conventionally, when we talk about knee osteoarthritis, we've talked about it in the context of it being a wear and tear disease, or this degenerative disease in which the cartilage wears away inside the knee joint or the hip joint or really any of the joints in the body here. And so when you look at this image, this is a cadaveric femur, and you're looking at the inferior portion of the femur, you can see that instead of nice, smooth hyaline cartilage covering the entire weight-bearing surface of the femur, the cartilage does have, severely damaged areas. And in this case right here, the cartilage has worn all the way through to the subchondral bone underneath it. So this is a chondral defect or potentially a post-traumatic osteoarthritis. But what you also see is instead of this nice, shiny, smooth cartilage covering the rest of it, it looks dull and thin. And that is the defining characteristic of knee osteoarthritis is the wearing away of the cartilage within this joint. However, I think it is also equally important to understand that that is not the only thing that happens when somebody has knee osteoarthritis. So although the cartilage does wear away, there are other biological and physiological changes that are also taking place in and around the joint that need to be addressed. And so those things include things like muscle weakness. Not only is the patient weak because they are not using the joint as much, but they actually have changes to the morphology of the muscle itself. So this muscle that used to be just muscle tissue has now been infiltrated with fat. And so there's actual change to the muscle tissue itself. In addition to changes to the tissue, we also see activation deficits. So there's this inability for the neurological system to get that muscle to fully contract. And it's important to recognize that these are not a consequence of the cartilage wearing away or a consequence of the pain. These are actually part of that osteoarthritis process. So it does affect more than just the cartilage of the joint. In addition to the muscle, we also have changes to the synovium of the joint and the synovial fluid. The fluid becomes less viscous. We also have bony changes. So in addition to chondral defects, we also have changes to the bone itself. In particular, we typically see thickening and sclerosis or hardening of the bone underneath the cartilage. And then patients can also develop bone spurs or osteophytes that are also present in the later stages of osteoarthritis. In addition to these biological characteristics, we also see changes in the way that a person moves. So what's interesting about these changes in movement patterns is not only are they a consequence of having knee osteoarthritis, but they are also predictive of who is going to develop knee osteoarthritis. So abnormal biomechanics are a risk factor for developing OA and also a consequence of all of these other changes that we see in and around the joints. And now there are numerous different types of deficits and abnormalities when it comes to biomechanics in patients with knee OA. The first thing, the most common thing that we see is this asymmetrical loading, where these patients tend to load their less involved or the less painful side. So, they rely on the good side. And this is something I'm sure we have all seen, as patients will even tell you, my knee hurts so bad that I have to rely on my good side for going up the stairs or for stepping on uneven terrain. I'm always relying on my good side. So the first thing we see is this asymmetry. The second thing we see is what's known as a stiff-legged gait pattern. And what I mean by that is that normally when we're walking, the knee should flex about 15 degrees to absorb the forces after initial contact during the gait cycle. Somebody who has a stiff-legged gait pattern keeps their knee in a very stiff position throughout that loading response. So instead of bending or flexing their knee, they walk with a stiff knee. And here's an example of somebody who's walking kind of with that stiff knee. And you can see here that at mid-stance, the knee should be almost fully straight, but this individual has about 20 degrees of knee flexion at mid-stance and about 23 degrees of flexion at initial contact. So not only are they keeping the leg in a kind of a stiff position without bending it, but they're also walking with what is known as a flexed knee gait, meaning that their knee is constantly in a position of knee flexion. And that changes the whole internal loading environment when somebody is walking. So instead of loading your knee in a position of extension, they're now constantly loading their knee in a flexed position, which increases the muscle activity required, which changes the place in which the joint is located, and can have consequences for both the cartilage degradation itself, as well as a continuation of these abnormal movement patterns. And so, one thing to keep in mind is that these deficits, these biomechanical deficits, can have negative impact on the affected side. But if I'm constantly overloading the good side, it can also affect that good side as well. And we're going to come back to that concept at the very end when we talk about joint replacement. So one of the things we see in patients with knee OA is kind of this vicious cycle here where, a patient has malalignment of the joint. So here's an example of somebody on their right leg who is in this really valgus position here. They're overly valgus. So in this malaligned position, the lateral compartments of the knee become excessively loaded. So this patient has excessive forces going through the lateral compartments of the knee. And what we know is that if I have excessive load through one portion of the joint, it's going to lead to degradation of the cartilage. And as the cartilage wears away, that malalignment is now just going to become worse and worse and worse. As the malalignment gets worse, the joint forces are going to continue to increase on this lateral side. And I get stuck in this vicious cycle of abnormal alignment, altered loading, wearing away of cartilage. It makes the alignment worse, which makes the loading worse, which makes the cartilage loss worse. And so it's this kind of continuum, and we need to intervene kind of at one of these places to prevent this cycle from happening. I'm not going to go a lot into treatment today, but keeping this kind of cycle in mind, I need to intervene at some point in this cycle to break that pattern from occurring. So again, this is just representing, you can see this individual is in valgus, and the joint reaction forces are going to be way lateral to the knee there, which is going to result in excessive loading. Here's just some examples. Again, the normal position of the knee is in a slightly valgus position. So here's an example of a knee that's in a slightly valgus position. This is a relatively neutral knee, meaning the angle between the femur and the tibia is close to 0. And this is a knee that's going to be in slight varus now. And you can see that its knee is in slight varus, has a loss of cartilage in the medial compartment. Again, cartilage doesn't show up on an X-ray, so I should see a nice dark area here that represents the cartilage within the knee joint. But this would be an example of bone-on-bone arthritis in which the cartilage has been worn away, which is in part leading to this varus positioning, but also potentially a result of that varus positioning. And alignment matters, not just talking about this vicious cycle, but when we look at research studies, alignment is actually going to be a predictor of who's going to go on to develop osteoarthritis. So somebody who is in a varus alignment has 4 times greater risk of developing medial compartment OA. Somebody who has valgus alignment is going to have 5 times greater risk of developing lateral compartment OA. And again, that's compared to somebody with a relatively neutral knee. So this static alignment, the position of your knee when you're in a weight-bearing position, is a risk factor for what happens to the cartilage inside that knee. What we also found interesting from some of these studies is that the person's body weight or their BMI increased that risk. So somebody who had a neutrally aligned knee, it didn't really matter if they were overweight or they were regular weight. However, if you had malalignment, particularly if you had moderate varus or valgus, then BMI became a strong risk factor. So maybe it's not only just the alignment, but it's also the body weight and the forces that are going through that knee when you have malalignment that are leading to somebody with an increased risk. So again, alignment's important, but particularly alignment's important in people that do have a high BMI. In addition to the static alignment, you can also have dynamic malalignment. And that means that maybe when you're standing and you're weight bearing on both of your legs, you have a nice neutral position of the knees. But as soon as you start going into single leg stance during functional activities like walking, you see a quick thrust in either a varus or valgus direction. And what the literature has told us is that regardless of what your alignment looks like, your static alignment looks like, if you have this thrust present when you're walking, it can increase your risk as well. So not only is static alignment important, but also what happens when this person's walking. Do they have a thrust? And if they do, that's going to increase their risk of developing arthritis. So again, we can intervene on these people that may be in a neutral alignment, but do something that's abnormal when they start walking in the frontal plane here. I'm not going to go a lot into detail about the adduction moment because typically we can't measure the adduction moment in our clinic, but we can look at some of these symptoms or some of these factors that are related to the adduction moment. The adduction moment can be conceptualized as kind of the distance between the center of the knee and the ground reaction force vector that occurs during walking. So there's two ways that I can increase the adduction moment. One is I can change the direction of this adduction moment. The more medial this ground reaction force vector is, the greater this moment arm is going to be, and the greater the compression forces in the medial compartment will be. So I can change it by changing the direction of this vector. I can also change the adduction moment by changing the position of the knee relative to this. So if my knee is in a very varus position, the knee would be further away from this ground reaction force vector, and it would increase the adduction moment. And the adduction moment's important because it's another biomechanical factor that's related to OA progression. So the greater your adduction moment, the greater your risk of OA progression in the future. Again, we'll talk more about this in the course, but this is a target for a lot of our biomechanical interventions, is that if I can reduce this adduction moment, then I have the potential to reduce your risk for developing arthritis in the future or preventing that arthritis from getting worse. So it's also important to keep in mind that not all asymmetries are going to be able to be visualized in a typical clinical setting. So this is just an example from patients after hip replacement. And when you look at their hip joint angles in the sagittal planes, this is hip flexion and extension during a rising out of a chair task. So they're sitting in a chair and then we ask them to stand up. What you see is that they are very symmetrical in terms of their hip angles. But if you look at their forces, they are relying on their non-operated side much more so than their operated side. So again, this is in individuals after hip replacement. Their pain has largely been resolved, but you can see that even though they look symmetrical, they still move very asymmetrically from a force standpoint. So again, we'll talk a little bit more in the course about how can I identify force asymmetries and how can I treat these force asymmetries, even if they look like they're moving in a very symmetrical pattern. We've done some work using a Wii balance board in which we're able to give patients feedback in real time about the forces underneath each of their feet. This is something we can also accomplish by using something much less technical like scales, bathroom scales. But it's important to keep in mind that even though they look symmetrical, they may not actually be symmetrical from a kinetic standpoint. There's a lot of tools that are out there that can allow us to capture biomechanics in a clinical setting. Again, we'll dive more into these in the future, but I just want to bring some of them to our attention now because I do think they are really powerful ways that we can capture somebody's movement or assess somebody's movement and also give them feedback about their movement patterns. So there are load soles, which are these shoe inserts that give real-time feedback of the forces underneath each foot. So again, if you want to take a step above using the bathroom scales in your clinic, you can actually use inserts that go inside the shoe that connect to a smart device like a tablet or a phone, and you can actually see in real time the person's force underneath each of their limbs. There's also some open source software. So Canovia is just one of these open source softwares where you can actually put stickers. They don't have to be any kind of fancy stickers, just colored stickers on the patient's joints, and you can capture joint angles. And there is a little bit of automation to this that you can capture not just, excuse me, not just a picture, but actually a full video of angles as this person's going through task. In this case, this individual was running, and we were able to capture their knee joint mechanics during this running task. So again, you can see that here using some relatively inexpensive stickers and a regular smartphone, we were able to capture knee joint angles during running in the sagittal plane for this individual here. Here's just an example of the load soles. So this individual is wearing the load soles in each of their shoes here. And what you'll see is the force profile for the left and right leg while this individual is rising from the chair. So again, you can use this tool to provide information on symmetry or to actually capture how much force is going through each of the legs in more of an assessment type of format. So again, a very powerful tool that can be used in a typical clinic. There are also some other tools out there. So one tool is this knee KG system, which is by Amovi. This is a system that allows you to capture three-dimensional biomechanics during various weight-bearing tasks. So the system is designed to evaluate knee mechanics in three planes, the frontal, the sagittal, and the rotational or horizontal planes during walking, but you are also able to capture some other tasks as well. So again, if you want to not just capture the forces at the foot ground interface, but actually want to see what the knee is doing, there are devices that are clinically viable or clinically friendly that you can use to capture three-dimensional real-time biomechanics of the knee joint. So I think as therapists, it's our job to kind of intervene in the individual's process of knee osteoarthritis. And we'll go into more detail about this, but it's not just changing somebody's pain. The joint pain that somebody experiences during arthritis leads to a whole host of other behavioral and physiological problems. So somebody has pain, for example, either from the initiation of OA or because they have some bone deformity or unfortunate genetics, and that can lead then to decreased physical activity. That decreased physical activity leads to muscle weakness, which leads to abnormal biomechanics, which leads to cartilage loss, which leads to more joint pain, and then this vicious cycle continues as well. So we'll talk a little bit more about how we can intervene and prevent joint pain, not just to make the patient feel better, but actually to stop this cascade of behavioral changes and physiological changes that come after that individual starts developing joint pain here. And it's important to keep in mind the time frame in which this is going to occur. So this doesn't occur over the course of a month or two. This is something that, of course, occurs over the course of 5 or 20 years. How many times have we heard about a patient who goes to see their surgeon, and the surgeon says, "Yep, you have knee arthritis. Come back to me when you can't take it anymore, or come back to me when you can't get out of the house, or come back to me when you can't work anymore." And if they don't have any interventions during that span of time, well, then these behavioral changes and these physiological changes become really ingrained and really problematic. So even after somebody has a joint replacement, it's really difficult to get back to what their normal status was before this joint pain developed. So for patients with knee OA, again, in general, the first thing you need to do is treat their physical deficits, their strength deficits, range of motion, if they have joint effusion, and as well as range of motion limitations at other joints. So if you're focused on the knee, just make sure you don't ignore the hip and the ankle, because that can change what happens at the knee as well. We're also then going to focus on treating the biomechanical deficits, and we'll provide plenty of information about how to do that in our course, but we want to do targeted motor retraining, right? Identify the specific deficits, and then you want to address those specific deficits so the OA doesn't get worse or they don't develop OA if they have an injury of the knee. This can be done with visual feedback, tactile feedback, a whole different, many different ways that we can provide feedback to the patients. We can also provide bracing, and there's a lot of different braces that are out there, but I will caution that you cannot just provide a brace depending on what their static alignment looks like. You really have to look at their dynamic movement. What does their knee do when they're weight bearing and they're walking or they're running? Because that might be very different than how they present with just their static alignment. And we'll talk more about that as well. And then for all of these things, if you're trying to change somebody's biomechanics, it's great to do it in the clinic, but you want to make sure that they are carrying any of these changes over into their daily activities as well. So they're getting that repetition outside of the clinic. And then finally, if all this fails, they can just have a joint replacement and that solves everything, right? Well, it doesn't really solve anything other than the pain and their functional abilities. So these patients are, their pain after surgery is dramatically reduced. You look 6 months or 1 year after hip and knee replacement, and most patients don't have any pain. And that is a wonderful, significant intervention for these patients. However, This is a graph showing what their pre-op ground reaction forces are on their operated and their non-operated, and their post-op ground reaction forces are 1 year later, as well as their trunk lean. And you can see from a biomechanical perspective, they don't really change. These patients continue to rely on their good leg or their non-operated leg, even after the pain has been resolved in their surgical or their affected joint. And sometimes when I go and I talk to people, they say, oh, well, it doesn't really matter. If the pain's gone and they're able to function in a better fashion, then that's fine. That's all we need. And I completely agree with that sentiment, except for the fact that what we see happening after joint replacement is that sometimes the good leg goes bad. And if you continue to rely on that good leg after surgery, you may actually start wearing out your good leg or wearing out the cartilage in that joint faster than you would if you resumed kind of a more symmetrical and normal movement patterns. And we'll talk a lot more about this as well, but this is the potential consequence of not addressing movement asymmetries after somebody has a joint replacement. It's great to rely on that good leg, but if you continue to do that, it may actually make the problem worse in the long term. So to wrap up here real quick, keep in mind, when we talk about biomechanics and OA, it's much more than just static alignment. You have to actually watch the person move and see what their biomechanical deficits are during walking or running or stair climbing to get a full picture of the interventions that are going to be most appropriate for that individual. And if we are addressing the biomechanics, we want to bring that movement back to normal. Change and reduce the abnormal frontal plane motion, stop the thrust, put the knee in a neutral position, maintain normal alignment, get rid of that stiff-legged gait pattern, normalize the shock absorption, and then finally reduce the overloading of the medial lateral compartments of the knee by reducing the adduction moment. And there's a lot of strategies to do that. If you are going to change the abnormal biomechanics, there's a lot of ways you can do it. You can brace, you can give targeted exercise, you can do movement retraining, and then finally surgery as your last resort. But we know that joint replacement fixes the pain. It doesn't stop the movement asymmetries. So even after the person has the joint replacement, a lot of these strategies that we talked about in terms of preventing OA from getting worse are going to be just as important after surgery as well. So I hope this gave you a little bit of a preview about some of the things that we'll be talking about in the full course. And I really hope to see you there, and we can dive into this in much more detail and do a lot more hands-on training for both how to assess biomechanics and then also what type of interventions are going to be most appropriate for the patients afterwards. So thank you very much, and I hope to see you all soon.
Thank you, Dr. Joseph, for such an entertaining as well as an enlightening talk on biomechanics and OA. I guess many of the points that he mentioned are very enlightening. It's evidence-based, and it's going to give a new direction to the way we treat our osteoarthritis patients. I guess we came to know about how biomechanics and the changes that take place due to the asymmetrical loading or the stiffness or the malalignment can alter the mechanics of the patient entirely, and how total knee replacement is just not the answer, because in case we have not targeted the biomechanical changes, they get retained even post-surgery, and patient may not have so much of improvement except for the pain which goes away in his function and ADL. So I guess there's going to be a lot that we can learn, and I guess this is just going to be one of the teasers or the eye openers or one of the ads, as you can say, for whatever is in store for the lower limb dysfunction workshop that we are going to have in February 2023. Moving on, I think we are just going to have Dr. Anil Bhave, who's our course director for the lower limb dysfunction workshop. As I just mentioned before we started this talk, he's going to be our course director, and it's going to be a completely hands-on international workshop that we are going to have. Sir is our course director, and he's a practicing therapist for more than 40 years now. He has developed and patented many of the casting and bracing systems that are used for treatment of various lower limb dysfunctions. He has certified himself in ASTM, dry needling, kinesiological EMG, as well as the very latest blood flow restriction therapy, which is getting used in many of the Western countries for training the athletes as well as post-op patients. He has delivered more than 300 lectures nationally and internationally and has been an author of more than 100 peer-reviewed articles. I'll move on now to Sir just introducing the workshop to all our listeners to just get a hint about what's in store in Feb 23. So over to you, Bhavesh sir.
Hello, my friends in physiotherapy, as well as colleagues and students. I'm bringing you exciting news about our course in Pune, India on advances in lower extremity dysfunction, assessment to management from 16th of February to 19th of February 2023. We'll be doing this course in Sancheti Healthcare Academy, an institute in Pune. And this course is also co-sponsored by Capri for Physio, as well as Sona Rehabilitation Center in Baltimore, USA, where I work. My name is Anil Bhave, and I currently am the Director of Orthopaedic Rehabilitation, as well as Director of Gate Laboratory at Sinai Hospital in Baltimore. In this course, we'll be addressing manual therapy, blood flow restriction therapy, athletic and running analysis, exercise prescription, case-based analysis, IS team and taping, total joint prehab to rehab, demo for new techniques in dry needling, especially addressing fascia, biomechanics, and we will end the course on the fourth day with comprehensive post-test on real patient examples, and the students of the course will participate in discussion as well as demonstrating what they have learned over the 4-day period. In this course, we have a very prominent national faculty. First one is Dr. Deepak Kumar, who does not need introduction. He's very famous for manual therapy and mobilization courses that he has performed internationally as well as nationally. And he runs a very busy institute in New Delhi. The next one is Dr. Apurva Shimpi, who is the principal also of Sancheti Hospital. He'll be spearheading the efforts for taping techniques as well as some of the MFR techniques. Next one is Dr. Sona Kolke, who is a musculoskeletal and kinesiotherapy specialist and will lead the IASTM labs. In the international faculty, we have 3 from United States. First one, Dr. Joseph Zeni, who is Associate Professor of Physical Therapy at Rutgers University in New Jersey. His specialty is biomechanics and progression of osteoarthritis and disease-modifying strategies, as well as rehabilitation and prehabilitation of total knee replacement patients. Next one, Dr. Brendan Glacken is a manual therapist and he'll be helping Dr. Deepak Kumar, as well as he's a specialist in dry needling. And he will be addressing some of the fascial problems in the course. And lastly, Annie Newher, who is currently staff at our institute, and she's a specialist, orthopedic specialist in running as well as biomotion, and she has done tremendous amount of work in getting runners back to running again when they are injured, as well as athletes. And she's going to address some of those issues of the lower extremity also. This is an exciting opportunity for both practicing physiotherapists as well as graduating or master's level students in musculoskeletal medicine to get a comprehensive hands-on workshop. To register for the course, easiest way is to just email us at alld.pune@gmail.com. Once again, it's an exciting opportunity of hands-on course all day long, 4 days with post-test, and I hope to see you all there. Thank you.
So thank you, sir, for just again educating our viewers and listeners about all that is going to be there for the lower limb dysfunction workshop in February 2023. I'm sure everyone has got excited now about what's in store, and I hope the registration come. We have very limited registrations, and we have few seats remaining. So the ones who are interested, please book your slots very soon. It's a once in a lifetime opportunity. I don't know how we have managed to create this, this dream team, as you can call it, where we have got the best of everyone and they are just coming down to conduct this 4 days hands-on workshop just for you all. So please make use of this opportunity and register for the course or the workshop. I now would like to thank all our viewers for attending this talk, and till we meet again, this is a bye from me. Thank you.